What happens with age is that there's sometimes a gradual diminution of function. And some of it is a diminution of the ability to sense specific odors, but some of it is also a change in threshold. And we've studied some of those changes here at Monell. And the question is, if you have someone presenting to you that has a gradual loss of smell rather than an acute loss of smell, is that something to take into consideration in a different way, Beverly? Is that something that we have to be more concerned about other problems?
Well, the main, as you mentioned, there is a tendency for people to lose their sense of smell with age. But on top of that, smell loss is a very early indicator of a number of neurodegenerative diseases, most notably Alzheimer's and Parkinson's. So sometimes you can detect smell losses before other symptoms occur. More generally, there have been some recent population-based studies that have shown that olfactory loss is a very strong indicator, particularly in people over 70, of 5-year all-cause mortality. And it's independent of many other factors that play into all-cause mortality. And the thought is that there are two possible explanations. One is that it's a sign of poor regenerative capacity in general, because the olfactory system relies so heavily on regeneration. And secondly, it may be a sign of lifelong toxin exposure, which would tend to impact the olfactory epithelium. So it can, it's not a good thing to lose your sense of smell.
Yeah, I think, the gradual losses, the question always is, for gradual losses, do you obtain imaging studies? And there have been a number of meta-analyses in the literature that look at this. And basically, certainly if there is something in the history that suggests a neurodegenerative disease or a family history that suggests such an event, that you should look at obtaining an imaging study. And then the question is what type of imaging study to get. If you're looking at conductive losses, as Kai has suggested, the CT scan of the sinuses is what is generally appropriate. Because if we're going to treat conductive losses, generally what we'll do is we'll use the CT scan to plan those types of treatments. On the other hand, if you're looking at neurodegenerative diseases, then an MRI scan of the brain is what's indicated. There you can see early signs of Parkinson's and you can see early signs of Alzheimer's. So we've looked so far at the ways that smell loss happen, the association of smell loss and flavor. We've looked at conductive losses. We can talk a little bit about sensory neural losses themselves. How do these acute losses occur? And you do have situations where you have traumas, where you have clear evidence of someone in a motor vehicle accident or someone has fallen and struck the back or the front of their head, and then they have an associated loss. Interestingly, that loss isn't always immediate, but sometimes what happens is there's a contusion or an injury that plays out over the course of 2 weeks or so before people really notice the loss. On the other hand, what we more commonly see is the patient that presents to us who has a cold. And during the cold, they notice that they're stuffy and they can't smell very well. And they say, well, I'm stuffy. I can't really smell because I'm just all blocked up. But then the cold goes away. And a week or 2 weeks later, they notice that, gee, my sense of smell has not come back. And that is typically when they present to the primary care physician. And unfortunately, most primary care physicians will basically just say, wait, it'll probably come back, or they'll poo-poo it and take the blood pressure, and they'll look and focus on other more serious problems. And this is something that we'd really like to change as part of our anosmia awareness program. Because what we'd really like to do is for the primary care physician to take a more detailed history to figure out if indeed the person has sustained a loss of sense of smell, and then refer appropriately so that we can evaluate the patients. One of the greatest difficulties that we've had in the 25-year history of the Monell Jefferson Clinical Research Collaboration is really seeing patients 3, 4, 5, 6 months after they've lost their sense of smell. And that is actually one of the problems that flavors all of the literature in smell loss, that the interventions for smell loss occur too late. You know, imagine that someone would have a stroke and that you would see them 3 months after the stroke. So not really much that you can do to help that individual, and you can't really design studies that will show that you're going to help that individual. This is one of the things that really we would like to do, is involve our primary care physicians really in trying to identify patients that potentially have a loss of sense of smell earlier so they can be referred appropriately. Then we can assess the history. We can perform an examination to see if they've lost smell identification or if their thresholds are elevated. And we can do the nasal endoscopy, look at the inside of the nose, and order the appropriate studies. And then hopefully we'll be able to advise the patients on different treatments. Because of the difficulty in doing the research, these treatments are few and far between. But there are some things that patients need to do who have lost their sense of smell, even apart from treatment. And I'd like, Beverly, maybe for you to talk about some of the lifestyle changes that anosmic patients must make.
Well, you know, the most obvious thing is they more than anybody else are in need of smoke detectors. So they should probably have more in their homes than most people do. Many people who have gas in their home are not aware of the fact that there are home gas detectors available. You can just look on Amazon and find them. But if they have gas in their home, that's a real problem because they can't smell the leak. They need to label and date foods that they store so they know when they need to throw them out, since they can't smell spoilage. And the final thing, which a lot of people overlook, is that when they're working with strong chemicals, pesticides, paints and solvents, cleaners, they need to be sure they're in a ventilated area or that there are others present. We've had a number of patients come in over the years who've had major accidents using like pesticides in their home, not being aware of how much they had actually sprayed because they couldn't smell it. And, you know, having somebody come home and have to drag them out because we're slowly poisoning themselves. So those are some of the main issues that people have to be aware of.